We're going to be having a panel discussion that's going to include Dr. William Richie, as well as Dr. Mary Harkleroad. Well, not doctor, sorry, but Ms. Mary Harkleroad. There are two local practitioners that are going to share their insights with us on evidence-based practices to address geriatric mental health. Dr. Richie is Assistant Professor and Vice Chairman of Professional Training in the Department of Psychiatry and Behavioral Sciences at the Lloyd C. Elam Mental Health Center at Meharry, where he serves as Residency Training Director. Dr. Richie completed his psychiatric residency at Howard University and later served as Assistant Professor of Psychiatry and Director of Inpatient Psychiatry Service at Howard University Hospital. Dr. Richie has been honored as a Distinguished Fellow of the American Psychiatric Association, is board certified in both forensics and general psychiatry. Our second speaker is Mary Harkleroad, is a licensed clinical social worker with over 35 years experience providing assessment, clinical, and supportive services to family seniors and their caregivers. She served as a social worker in medical and behavioral health hospital settings, and she directs the Geriatric and Memory Disorders Program at Parthenon Pavilion. For over 20 years, Ms. Harkleroad was in private practice with an interdisciplinary psychiatric group where she participated in numerous clinical trials for seniors with dementia and focused on clinical practice of senior adults and family caregivers. Currently, Ms. Harkleroad is the Education Committee Chair and President-elect of the Mental Health America of Tennessee. She also serves as Senior Care Consultant, Educator, and Support Group Facilitator. First up will be Dr. Richie, and then he'll be followed by Ms. Harkleroad.
Good morning. Thank you so much for allowing me to address you today. I stand before you as a card-carrying member of the sandwich generation. However, I've only been a member for the last 3 3/4 years, as that's the period of time that we've been blessed with William Jr.'s presence. Usually I have a slide, for my presentations, I have a slide with his doing something where I ask you to do what I'm going to ask you to do right now, which is please silence any cell phones or pagers, and please fill out any hard copy or online CME and feedback forms, as I'm always trying to do what they told me in the Air Force, which is fight for feedback. So our objectives today discuss health disparities relative to mental health problems of aging adults, the importance of cultural competence, both in general mental health care and in mental health care of the aging population, the importance of addressing health disparities in integrated behavioral care networks, and the need for screening mental health disorders in a primary care setting, and strategies for doing that screening earlier. The older adult population is increasing in numbers and will continue to grow at an ever-increasing rate. In 15 years, 20% of our population will be over the age of 65. And that racial and ethnic diversity that we see currently will also continue to grow. And so we need to be prepared to address the serious mental health needs of both of these populations. So here you have a Venn diagram of the various factors that influence healthcare disparities. And as you see, age is one of those major factors in the individual. But there are system factors, local public health and primary care strategies that need to be improved. And then there are community factors, including education, healthcare access, community norms of behavior with regard to our older population, and the type of neighborhood that that population might be living in. So some of those factors influencing healthcare delivery. One of the economic factors is limited access to services due to factors related to income. A lot of our older folks are on a fixed income. There are issues involving financial services for lower income individuals, and these must be addressed. Another factor is that women will likely be at a higher risk for poorer health status, both physical and mental health care, because they are likely to be the caregiver for their spouse, and they are more likely to live alone, having lived longer than their spouse. Case in point, my father died 11 years ago this December, and my mom's been carrying on in his absence, though the struggles are increasing in variety and frequency. And there are some ethnic trends that must be addressed, and that's where this issue of cultural competency comes to paramount importance, and we'll discuss that in some later slides. Facts about older adult behavioral health. Depression and anxiety disorders are among the most common mental health problems in older adults. 13% of the U.S. population suffers from a mental disorder, but approximately 19% of all suicides are related to some sort of mental disorder in an older adult. And older adults die by suicide at a higher rate than the national average, and these rates increase tremendously after age 65, primarily among European American males. And so if you look at risk factors for suicide, what you see is that if a European American male over age 85 is manifesting symptoms of depression, anxiety, that person is at the highest risk for committing some sort of self-destructive act. So we look at the epidemiology of geriatric depression. Of the 35 million seniors in the United States, an estimated 2 million will fit the diagnostic criteria of a depressive illness. 5 million will have some sort of what we refer to as subsyndromal depression. And less than 10% of those who actually fit the criteria will actually receive treatment. And that factors out to about 1 in 10 Americans over 65 who will be suffering from major depression. And as I said earlier, for people over 65, they constitute about 19% of all suicides, whereas they are only 13% of the U.S. population, so they are overrepresented in that regard. And as I said earlier, European American men over age 85 have the highest suicide rates. And, there we go. In terms of Alzheimer's and related conditions, risk factors are as follows. Gender, women more likely, and that's because they're more likely to live longer than men. Age, If you're over 65 and if you're over 85, your numbers increase dramatically. Interestingly enough, those with more than 12 years of education have a 35% greater risk of developing dementia than those with with more than 15 years of education. And African Americans are reported to be more likely than European Americans to have the disease. The reasons for that I'm still looking into. Alzheimer's is the most frequent cause of dementia, or the most common form, and it's characterized by a deposition of this beta amyloid peptide and glial activation in senile plaques and selective neuronal loss, most notably the nucleus basalis of Meinert. Some of the symptoms are memory deficits, disorientation, and misinterpreting spatial relationships. People get lost, they wander. Speaking and writing difficulties, judgment and decision-making issues, and difficulty with planning and executing familiar tasks. In addition, there are references in the literature to a change in an individual's personality, where previous personality factors seem to become enhanced or highlighted. So, since anxiety seems to be an issue or a symptom very prominent in patients with Alzheimer-type dementia, anxiety medications or anxiolytic medications are something that needs to be examined. Recent information suggests that the use of benzodiazepines and the density of that usage may be itself a risk factor in the development of Alzheimer-type dementia. We're still teasing this out, but this is hot off the presses. And the question arises, is it the benzodiazepines themselves as a separate, isolated risk factor, or is it that benzodiazepines seem to be administered in individuals who develop these symptoms associated with the illness? There are only a few studies that are looking at this that I've reviewed. Certainly, it is well understood and generally accepted that the administration of benzodiazepines in older adults is a problematic situation, and some alternative pharmacologic strategy should be considered rather than chronic, long-term administration of benzos. But we have new data that suggests that the benzos themselves may be an isolated risk factor. So we have a study that was recently published regarding the usage of these medications in this illness. And the results of the study were that benzo use was associated with an increased risk of Alzheimer's disease. The risk was increased by 43 to 51% among those who had used benzos in the past. And the study, of course, had some limitations, but the conclusions were that the use of these medications is associated with an increased risk of Alzheimer's disease, the stronger association observed for long-term exposures. Unwarranted long-term use of these drugs should be considered as a public health concern. So, bottom line, if a person is on benzos, please consider tapering, and cross-tapering to some other anxiolytic. My suggestion would be that you do so incorporating a strategy that also includes some sort of psychotherapy. On the other hand, blazing up some dubage. Recent research suggests that marijuana, cannabinoids, actually have a protective effect on neuronal structure and function. Yes, folks. I'm not advocating people going out and, say, moving to Washington State or Colorado. However, let's see, Centennial Hospital has a conference a CME conference in January at Breckenridge, Colorado, or Beaver Creek. We'll have to see. But yes, cannabinoids, the ingestion of cannabinoids does reduce the formation of senile plaques. So I leave you to those conclusions, and I will make these slides available for your perusal. But with that lighthearted treatment, let's take a look at some more serious information. We have something called the PRITE, Psychiatry Residency In-Service Training Examination. We just did it. So any psych residents here? Any geriatric residents here? Okay. You saw this question about risk factors and how to protect yourself in terms of civil penalties. The bottom line is you should consider suicide risk factors certainly in all of your patients, but more importantly, for those patients who might satisfy some of these diagnostic criteria for depression, Alzheimer's disease, and other chronic medical and psychiatric disorders. And so you have a list of suicide risk factors that you should document the presence or absence of in your patients. This is a mnemonic to help you remember some of these risk factors. And finally, let's take a look at stigma and cultural competence, and we'll proceed briskly. Reducing stigma, both in terms of aging and in terms of mental health care, should be our primary concern. This will allow people to access systems of care more readily. Strategies to overcome some of these barriers are educate the public, and the campaign should target older adults, their children, and the general population. And this issue of cultural competence, here you have a definition from the U.S. Department of Health and Human Services. My recommendation is that every learning opportunity and every CME and every teaching environment should include some sort of cultural competency curriculum, and I assure you that we have one of those in the Department of Psychiatry at Meharry Medical College. It is an increasingly important issue when you look at the changing demographics of our society. And I can't stop without giving a shout out to the Affordable Care Act, which will improve the health care of juniors, seniors, and that sandwich generation that I told you I belong to right now. I want to thank you for your attention and your allowing me to come here and brief you guys on a few of these important issues. Thank you very much.
Okay, this is one of the things that we know about geriatrics. If we've been in it for a while, we have to be creative, we have to be adaptable, and we certainly have to kind of flow with things. When I was contacted by the Educational Center to talk today on the panel and to be a part of this panel, it was suggested that as a community provider and as a licensed clinical social worker, that I really might focus upon two areas. One, providing care across levels of care, evaluation, treatment services across various levels of care. Since I began my own geriatric practice some 35 years ago, first off in a medical hospital setting, secondly in a geriatric psychiatry hospital, where I, along with Dr. Charles Wells and Dr. William Petrie, began to evolve and develop a geriatric program that had a 24-bed general geriatric unit, and then added some years later a 12-bed Alzheimer's disease-related disorders unit. The reason that's important is we spent some time at the front end talking back and forth about what are some of the general principles, what are the kinds of things that we find to be important in terms of providing comprehensive evaluation assessment, treatment of the individual, as well as addressing needs of caregivers. The focus of the presentation then is really kind of zeroing in on and trying to paint a picture of how some of the general principles that guided us in an inpatient setting might be translated into an outpatient geriatric specialty clinic that happened to be embedded with a general psychiatry practice. And let me tell you, that was no easy undertaking, because we were coming with some philosophical bases about how we delivered care, some tenets of treatment that we wanted to pursue in an outpatient clinic. And since it was in the early 90s, we came with the notion that we would be charging a global fee. Those of you that have been in the field for any time period at all know that global fees in geriatrics went by the wayside and oftentimes were attached to academic settings. And when we went into this endeavor, we basically began to spend some time thinking about what is it that we want to accomplish. First off, Dr. Wells and Dr. Petrie and I talked about what are we going to name the clinic. And symbolically, we came up with the name of the clinic, the Geriatric Evaluation Family Services Clinic. And the reason we came up with that name was to basically symbolically say to referring physicians, referring specialists, and to families that were asking for evaluation through our clinic, is that number one, we want to provide a comprehensive evaluation for the individual, and we want to meet family caregiver needs. The second area that I was asked to speak to today was recognizing and responding to caregiver depression. Clearly, to be able to cover both of these topics with any depth and meaning, we can't do that within 20 minutes, and I'll have to try to do some movement ahead fairly quickly on things. And let me just describe briefly the practice modality and the practice kind of approach that we had in our geriatric clinic. I was tasked with developing a multi-dimensional evaluation instrument, and it did much of what Dr. Blazer and some of the other pioneers kind of noted to be important aspects. It was a multi-dimensional, not a checklist. As a matter of fact, we early on got some complaints from families because it was an 8-page geriatric questionnaire that we sent in. But I will tell you that these people dealt with these in a very serious kind of way, because part of what we asked was personal and family information, some information that told us a little bit about marital history, military history, professional, and then we asked the specific questions. Why are you coming at this specific time to our clinic for evaluation, and what is it that you seek from the way of services and help from us? Now, if it happened to be coming from a from an individual who had dementia, oftentimes the answer was, I have no problem. I'm coming because my family's sending me. But we also encouraged families to send us their own information about why were they coming for the evaluation. We set up 2 visits. First visit was either with myself as a licensed clinical social worker or with a nurse practitioner or with a clinical nurse specialist, and we set up an hour and a half. And in order to make that an efficient time, we basically had the geriatric questionnaire that came in with the patient. We had medical records that came preceding them or along with them, so that when I saw the patient or the nurse practitioner saw the patient, we had an enormous amount of information. What we had on our geriatric questionnaire, I'm sure Dr. Blazel will recognize, because some of it had to do with some of the components on the old ORS evaluation model. We looked at personal history. We looked at family history. We looked at spirituality, social activities. We had embedded within that a functional assessment evaluation form that included activities of daily living where people checked did they do it on their own, or did someone else help them with some of those activities of daily living. We had a medical checklist that, even though it was a checklist, we said, did it help? Do these interfere with your activities a little, a lot, or none? We had a list of medications, including medicines that were over the counter, and we said, bring in your brown bags when you come to bring all of your medicines in, so that we could look at medical and look at medicines. And we also looked at history in terms of prior psychiatric, prior mental health history of families, as well as social and activity involvement. So when we saw the person, we really were able to do precisely what Dr. Blazer talked about, is that we were able to focus upon that individual. And in contrary to my going to my primary care physician, where someone comes and gets me and sticks me in the room, every one of the clinicians, including the psychiatrist and myself and the nurse practitioner, walked out to the waiting room to get the patient. It was not necessarily just to walk out and get them, but it was a part of that observational process. What were we seeing when we went out? How did the caregiver look? Did they look worse than the person that was being referred in? And frequently that was our first clue of what we were dealing with. We watched how they walked down the hallway. We watched how they would come in our office, how they would respond to please sit in this chair. And we would notice people who wouldn't be able to find a chair, or that we had to go over and show them what a chair was. We interviewed that person. We used a couple of scales routinely. We used a geriatric depression scale. We used a mini mental status scale. Typically, as time went on, Dr. Petrie wanted to incorporate a MOCA scale, which is a Montreal Cognitive Assessment Scale, which really looked at some different things. If people came in with serious language issues, we might be using the clock draw. We might also be using name as many animals as you can in 60 seconds, so that we had a cadre of things that as a set of clinicians. I can tell you, as a clinical social worker, I was never trained in any of this. I learned much of my own geriatric perspectives, the philosophy of evaluation and individual assessment from Dr. Charles Wells, from Dr. Petrie, from the nurses that I had the privilege of working with, and a lot of research, because those of you that are in geriatric care, part of what you must do, I think, is understand normal aging as best we can. What are some of the life transitions when one are in their 70s and 80s and 90s? And we saw some folks in their hundreds. The oldest that we saw in our clinic was 104 who came in depressed, and she was treated and was effectively able to live a couple of more years. We had to have, even as licensed clinical social workers, had to have some baseline information about what are some of the key medical issues. How does strokes, Parkinson's disease, how does this play out, and how does it intersect with some of the mental health issues that are being identified, so that at the back end of that initial evaluation, we had already had an opportunity to spend some time with the family to find out not only what the person was saying, because oftentimes they would come in with a complaint There's nothing wrong. I'm here because my family's here. I'm taking this Lexapro because they told me I had to. Or whatever the answer is. I have a little bit of memory problems, but not much. The doctor, I just did neuropsychological testing, and I blew the socks off of the testing, and yet they couldn't tell me what the findings were, and the spouse comes in and says they determine that they have moderate Alzheimer's disease, and they have far more problems than you probably see because of their good social skills. Again, part of what was helpful to us is having that questionnaire in front of me where I could talk to someone about such things as, tell me about your family, how many children do you have, where do you live right now, what do you do during the day, because frequently people would, in fact, confabulate answers, sound great, and when they go to, and this was one of the real frustrations that many families had, is we just took him to his primary care physician and he says he's great when he's not sleeping, when he's up agitated at night, when he's getting lost in the car, and the like. And this is not moving. So when Grace asked me to do this, I began to kind of think about how can I cover all of this material in a way that for practitioners and persons that are in the field, it can be meaningful at all. So I tried to think about what are some of the common elements of what we did and how we formulated our evaluation process that we not only could use in a clinic, but also translate into a small consultation practice that we had when we went out into nursing homes, into assisted livings, and to memory units, because we eventually had a very small consultation practice that did outreach services. Obviously, I didn't take out an 8-page questionnaire to the facility because, number one, we were going into a host facility. It was a nursing home facility, it was a rehab facility, or it might be a memory unit or assisted living or a continuing care community where we were being asked very, very specific questions. Typically, they would fall within several domains. We would get a referral for someone who was not participating in rehab because they were lying in bed and not eating. Or they might be lying in bed and not eating and saying, I want to kill myself and I want to die, and therefore they wouldn't get out of bed. So that might be a reason that we were called in. I will tell you that uniformly what we did as a consulting service was to always get permission from the family to see that individual in the nursing home. What we had to do is be clear about who was a DPOA for medical decision making as opposed to who was paying the bills. But it was important to us, again, the paradigm that we were seeing the individual, but we also needed to have family input, because any of you that have gone into nursing homes in this day and age know that you're seeing people quicker, sicker, and sometimes with inadequate medical history and information, and they're coming in on a slew of medications that sometimes you don't have a clue about what the history is and why they're on them. And consulting pharmacy comes in, and their first idea is because they're on certain kinds of medicines, they want to discontinue. So that's a challenge that we had to address. We needed to understand the medical situation in these host facilities, why we were being asked to see the person, what the family's expectations were, and then if the physician made a recommendation of medication, we always made a link back to the family. You know, we might, in certain skilled units where they had a clinical nurse specialist, say, please contact the family, let them know that Dr. So-and-so is going to start Lexapro for, at this level, to address certain depressive symptoms, but in fact, please tell that family member to call us if they want a sit-down conference so that we can explain the thinking, the rationale, what our thoughts are, etc. The other kind of thing that we did, as that's already been alluded to, is as a social worker, I was trained in terms of person and environment and the systems approach. So that part of what we began to look at is some of the things that have already been alluded to. When you go into a assisted living environment, when you go into a rehab environment, part of what you're looking at is not just the behavior, but when does it occur? What are some of the precipitants of that? And also, how does it affect others? One lady we were called in to see who was 85 because she was, quote, hallucinating. This was a lady that was sitting by her window, very pleasant, looking out, and this is at Richland Healthcare Center, and those of you that have ever been there know that surrounded with nothing except asphalt. This lady was looking at, talking about the barn outside, talking about the cows, how pleasant it was. Essentially, we had to make the decisions about she wasn't harming anyone. These were pleasant thoughts and decisions, so that therefore she was not in need of active treatment. We did make some suggestions that, next slide. It's not moving. Okay. Next slide. I think we've noted some issues in long-term care. One I do want to speak to is not only are people coming in sicker in long-term care, but they also are coming in with more complex problems, and there certainly are now high-volume organizations that are going into nursing homes to provide long-term care, and that can be a plus, but at the same time it can be problematic, especially when it's based upon high levels of participation in volume. So the assessment tools that we used were fairly consistent. We used depression scales. We also used scales that had to do with agitation and cognitive kinds of impacts. Now, the second area, and we're going to have to move through this fairly quickly since I don't have very much time, is really looking at the caregiver, because much of what we did was not only dealing with the common mental health issues, but with people who are coming in with atypical dementias in our clinic and in these various settings, who might have Alzheimer's disease at the mid or late stages, who might be manifesting very severe behavioral kinds of issues. And part of what we spent a fair amount of time with, and that was my passion, of working with caregivers. Generally what I would be doing with caregivers would be not only seeing the individual, but also spending time with caregivers to determine what are the symptoms you're most concerned about. We did a caregiver scale. We did a caregiver burden in many instances. But I think, as Dr. Blazer as well as Dr. Rabins have noted, that the key issue is listening. Listening to a family as they describe to you the kinds of problems that they are facing. Next slide. Okay, next slide. And next slide, because we've already talked about the some of the assessment issues. Holistic and best practices include the psychosocial and family-based model of care, where we're doing an individual interview with the person and also with families. Next slide, please. It's multidisciplinary, and it can be with any kind of setting and with any combination of people. It might be primary care where there is a mental health person embedded. Next slide. We know the impact on caregivers can be great. Certainly there are losses associated with Alzheimer's disease. There's increased mortality that's associated. There's stress burden. But in addition to that, I think we also have to understand and be clear about, in addition to the stresses, many families find that it is a sacred moment to be able to provide care. And we not only need to be able to support the individual, but also to be able to address and understand when anticipatory grief which is a normal aspect of the losses associated, becomes more pronounced and more profound with the individual, and it is a depression. Up to 40% of caregivers are thought to have depressive symptoms. Next slide, please. And we know the sources of stress, and I'm going to refer you back to really the the slides on that, because there are an enormous number of stresses for caregivers. Next slide. We also know that some of the tools that we use are caregiver problem checklists, screens for caregiver burden, and certainly the interview. That, to me, was the most important kind of thing that we did in terms of recognizing. Next slide, please. I also identified some of the major supports that caregivers needed to help improve their own coping abilities over the course of illness at different stages, and I refer you to that also. Next slide, please. And last slide. Okay. The summary and general principles that I want to leave you with is really underscoring what Dr. Blazer and Dr. Metter and Dr. Rabins and others have already said today. Number one, mental health issues in senior adults are complex. They often are accompanied by co-occurring medical issues, and we need to be able to individualize and complete an assessment that is a multidimensional assessment based upon that individual. We need to respond to the family needs. We need to be able to address concerns that they have, and there's an increased need for practice standards across the board. I think that one more, please. Okay. Senior adults with depression and anxiety can respond to treatment, and oftentimes there's a very negativistic approach. I think that's important. It's important to know that Alzheimer's disease is stressful to families. In my own experiences, it is particularly stressful, and there is a special journey for spouses. And I'll leave you, and it's hard to look at. It's actually hard to see the very last quote up there, but I think it is indicative and does pull together some of the thoughts I have in terms of the individual, the pain the caregiver has, the importance of addressing in very simple and common sense kind of ways the needs. And it's by C.S. Lewis, and it was written at the time of some great, if you will, grief in his own life in terms of the loss of his wife, where he says, "A glimpse is not a vision, but to a man on a mountaintop road by night, a glimpse of the next 3 feet of road may matter more than a vision of the horizon." I think that you as clinicians are the ones that can oftentimes help people in those next 3 minutes, those next 30 minutes, so that there is a sense of hope that you're able to imbue and help, and oftentimes this does alleviate the propensity to depression, the propensity to strong anxiety on the part of caregivers. And I'm around later. I have some tools that I'll be glad to show you, some case examples that I had hoped I would be able to share with you that were real life folks that we saw in nursing homes as well as assisted living and in the clinic, because I think they would have been a way to illustrate even more some of the points. But thank you so much.
Next, we're going to have the panelists discuss some of the issues around mental health and the care of the elderly. If you have questions, we should have mics floating around, and then the panelists can sort of share their different viewpoints of this. Do we have any questions first? Dr. Richie sort of teased the audience a little bit with this, but I'm going to get the panelists' reaction to see the various viewpoints. This issue of cannabinoids and its use, given the issue of substance abuse and the propensity to self-medicate in the community, how does news of potential protective effects, you think, impact A, the illicit use, B, the future medical use of substances like cannabis? And Dr. Blazer, you know I'm looking at you, so you pass the mic to Dr. Rabins, but go ahead.
Well, first, I actually haven't seen the studies about protection, so I've learned something. I'll have to go and look. I do think the data are pretty convincing that heavy exposure in adolescence does lead to cognitive impairment in some individuals. So I think we have to start there and realize that that's a serious public health issue. Whether these are animal experiments or I don't really know more about that, but I will say that I think it's unfortunate myself that the FDA hasn't really allowed people to study cannabinoids more. And so, in fact, there are places in the country where people are using Marinol, which is a commercially available form of cannabinoid, to treat behavioral symptoms in Alzheimer's disease. And because they stated they would never allow it to be commercially available, nobody then would fund studies to do it, and I think that's unfortunate. Now, Dr. Glazer will...
I really, on that topic, have no comments. I actually do have, if I could, just for a second. First off, I really appreciate Ms. Harkleroad's comments. There's nothing quite like a good social worker, and she's an example of that. I personally know this because she actually has helped my family in the distant past. I wanted to make a comment regarding what Dr. Richie said, though, because I think he brings up he covered a lot of material, but he brought up an extremely important issue in talking about looking at diversity across these mental disorders. And I'd like to just give you one example of that, and that is, first point would be, not all minority groups are identical. So if you look at something like substance abuse, you have very high rates in Native Americans, and interestingly enough, you have quite low rates in African Americans overall. Now, there's sort of a myth out there that it's the African Americans that have the major problems, but that's actually not the case. So you see great differences, and you have very low rates, for example, in Asian Americans, but we see changes occurring in Asian Americans because second generation Asian Americans are coming along, and that becomes a real problem. So looking across age groups and looking across racial ethnic groups, I think it's absolutely critical when we consider diversity. Second thing is that treatment patterns in different racial ethnic groups can be quite different too. I know depression, and I know, for example, that African Americans are much less likely to take antidepressant medications than Caucasians, and we don't know all the reasons for that. We don't know whether that's good or bad, because I think probably antidepressants are overused in whites. But nevertheless, there are differences in their use of medications and their response to certain and willingness to participate in certain types of treatment. So many physicians just want to lump all of this together. Or if they want to divide it, they divide it into whites and everybody else. And that is not the way to go in terms of looking at diversity. Mm-hmm.
All right, I'll give y'all another shot because I'll stay up here and ask them a bunch of questions.
I'd like to address caregiver support issues as well. There are some newer programs. Some states are permitting for their Medicaid programs patient-directed funds where a family would be given a certain amount and they can use it for support services. Is there any information about programs like that supporting caregivers, particularly for Alzheimer's, but perhaps other illnesses? Any benefits or would you have any recommendations on how those programs could be better directed to help with the caregiver stress that you mentioned? And Mary, if you'd like to start, I'd be happy to hear your thoughts.
Yeah, let me just start from the standpoint, certainly I don't know how this is being played out elsewhere. Locally, what our own experience has been is that oftentimes the support services are either being bootlegged into assisted living communities versus any funding sources. I happen to be working with a corporation that has developed a contract with me to come in to not only provide support services, education services, but also to provide some basic help and supports. Not many facilities, in fact, are willing to do that. So I am unfamiliar, at least, and there may be some other people who are experts, of whether there are some funding sources in this particular state and region that are doing that. But oftentimes, if you are going in as a consulting group into a care facility and you're seeing folks, and this is part of what we did as a piece of our consultation practice, we tried to embed ourselves in a couple of areas. We tried to embed ourselves by being on the quality assurance team. Didn't get any money for that, but it was a piece of something we felt to be important. We participated in behavior, and we ran support groups for that facility. So I think that so much is very individualistic yet, and many corporations are not investing in families. And they're clearly not, particularly assisted livings and memory units, investing in staff education. So, you know, that's encouraging to know that that is happening, and I would certainly hope that Medicaid, if we expand, that may be an area where families would be able to have access to those sorts of services. They're also embedded oftentimes in daycare programs, you know, where there are some services provided, but it's not under any funding extra source, and that is just a part of the given of the program, if that's helpful, Dr. Powers. Wish there were more.
I think it's just a new.
My question is for Dr. Rabins. In terms of Alzheimer's prevention or treatment, what do you see as toward omega-3s, fatty acids, fish oils, such as that, as a treatment?
Yeah, I think in general, if you look at all the dietary treatments or correlates of a risk for getting Alzheimer's disease, I do think the best data are that people who in their natural diet have had higher intake of omega-3s are associated with a lower risk of getting Alzheimer's disease. I also think there is a developing database suggesting that the so-called Mediterranean diet, which partly includes that, but less meat, more vegetables and fruit, does seem to be associated with a lower risk of Alzheimer's disease. I think the challenge always in epidemiologic studies, of course, is whether it's causal or not, because you can imagine that people that eat more fish, for example, might do all kinds of other things that are better health-wise for many other things. I don't think there's really good evidence of any vitamin or mineral strongly associated with prevention. You can find individual studies, but I think when you look at meta-analyses, they always seem to fall apart. So that would be, I think, the one positive I would say, that I think either naturally occurring omega-3s, because there have been some negative trials of supplements of the oil itself, might well be a prevention in the Mediterranean diet.
Here's one.
Oh, sure.
Question to Dr. Rabin about etiology of AD. Is a neurofibrillary tangle or a senile plaque?
Speak to the mic so everybody can hear you.
Well, the diagnosis of AD, it depends on autopsy, not clinical. And neurofibrillary tangle or senile plaque is aging process. So how do you make diagnosis? Does the people do research as far as the memory deficit? Does the tangle or neurofibril as a more in the frontal lobe? So if you don't know the causes, it's difficult to get into the accurate diagnosis. And so it's clinically, it's very difficult to get the patient better outcome as far as the treatment is concerned.
Yeah, so I think there's at least two questions here. One is since the diagnosis of Alzheimer's disease now is really clinical, is there even any benefit of that? And I think since I started my career before, most people, not even most doctors and nurses, never heard of it. I think making people aware of how prevalent this is and the associated morbidity is very important. I don't think there's any proof, I'm embarrassed to say, that accurate diagnosis or earlier diagnosis is beneficial. But not every question can be answered with science, and it just seems to me that when you look at all the distress that's associated with the disorder, both from the person who has it and the family, that being as accurate as we can is the right thing to do, and it's the only way we're going to get the NIH to spend more on research. We're going to develop the psychosocial resources that will help keep people at home as long as possible, and I think develop the best long-term care facilities, because that's an essential part of it. I think you also asked, what's the cause of it? I think the honest answer is we don't know. And even though one can make a good story that the beta amyloid protein abnormality begins way before symptoms, and that it's associated with killing brain cells, a whole variety of indirect pieces of evidence, I think the truth is we don't know, and that's why we really need research. We need people doing really different things. The fact that 80% of the therapeutic research is focused on beta amyloid removal, I think is a mistake. And so hopefully, now that it's clear that at least so far all the trials have been negative, there will be a broader effort to try to figure out your question. What's the cause or causes? It's not one disease. I think Alzheimer's is a syndrome. It has genetic autosomal dominant causes. There are environmental causes. At most, I think the evidence suggests that it's about 70% genetic. So if it's 30%, and those numbers might not be exactly right, but if about a third of the causal contribution is in the environment, we need to be teasing that out as well.
I did see a program, and part of it was that it showed an elderly woman who was bedridden and had Alzheimer's, and her son very much wanted to give her the 24-hour care, but he couldn't work and do that. So this pilot study was paying the caregiver an actual salary so that, and of course he loved his mom, so she was getting great care. It was cheaper maybe than a facility, and he loved what he was doing and got a salary, and I think that's a wonderful idea.
I have one over here.
This question or statements for anyone on the panel. Access. I've heard a lot of good information about the clinical side of the house, but getting people into a position to use the services that are available. I think it was Dr. Richie mentioned Obamacare, and I'm quite sure everyone in here is familiar with the Mental Health Parity Act of the 1990s, I believe, and I may be wrong on that particular year, but I think it's somewhere around that time. I did my dissertation on mental health and primary care, and one of the biggest things that I found was there is no access to mental health services in the communities that I visited for my dissertation. So is anyone thinking along the lines of how are we going to get, with this population of increase of people becoming age 65 and over, or 50, how are we going to get all these people into this?
I'll give a shot at that, and I don't have an answer. I think there are actually two problems. First problem is that we don't have clear ways to access the care that exists. What works best, I think, in situation is if there's some kind of coordinator of care or single point of entry where people can kind of get in. I think Ms. Harkleroad probably was that portal in her system, and then you have access to a whole series of services. But you've got someone knowledgeable about those services that in turn can they can coordinate that. So I think having a single port of entry is critical. And most primary care physicians have no idea how to access that single port of entry. But I think there's an equally important problem we need to recognize, and that is the number of people trained in providing care, from physicians through nurses, through social workers, through psychologists, through family caregivers, et cetera. We are grossly understaffed at this particular point in time. And so we've got a lack of people who are actually capable of providing the care as well. And so we've got these two issues, and you factor in there also this very fragmented approach to funding. Even though the Affordable Care Act is here, still care is very fragmented in terms of how it's put together, so it's inefficient. And so we've got a lot working against us. So I would really make a case for trying to develop models where we have where you can see a single port of care, but I also make a very strong case that we need to train more individuals at all levels to provide this care. And we also, through developing models, can in turn decide who can provide care at the best care at these given levels. We've got people overtrained providing certain types of care. We've got people undertrained providing care. We were mixed up. And so I think we've got to get that straight.
Let me add another piece to that. I think that, and I'm going to hit on something that Dr. Rabins made a comment on, and it had to do common sense approach, flexibility, because much of what I did in our practice was to really try to get an understanding of the person, what they would be willing to accept, what families would be willing to pursue and accept, and then creative ways to access those services. Case in example, we had a local pediatrician who had severe Alzheimer's disease that needed to be retired because he was still making rounds in wrong hospitals. We essentially came up with this huge retirement party, and his son happened to be a physician. And then we came up with a plan where he would be a, quote, consultant in a daycare program where he still could look at values and look at blood pressure. So we're talking about creativity. We're talking about what, if you go to a person with cognitive difficulties and say, whether you're a daughter or a professional or a physician, and say, you need to go to a daycare program. Do you think you're going to succeed in that? No. You've got to figure out from a, if you will, from a creative standpoint, how do you make that? Is it a rehab setting? Are they going to be a, quote, support? This guy, even though he was impaired, they gave him a list of blood pressures every single day, and he could identify those out of range and those in range, and he felt useful. So I think it is a matter of access, not just that, because we've got respite care that's out there, we have daycare programs that are out there, we have day programs that are embedded in assisted living, but I think the real critical issue is not just that we have them in access, but how do we present this in a way that makes sense to the individual and the family feels supported, and that they can come up with a, quote, what we call validation or a therapeutic lie.
Dr. Rabin, you wanted to add to that?
Can I just add two quick things? I think first that dementia and depression, and just focus on the elderly, are so prevalent that it's clear that primary care is going to have to provide at least 80% of the medical service. And so I think we just have to make sure that primary care training includes that, and it does. But I think we have to focus on that and perhaps reimburse people extra, because dementia is just a time-sucking service.
Well, yes.
And that's one thing. I think the second thing is we really need to focus more on non-physician providers. Mm-hmm. And I think that Walgreens and CVS and Walmart have it right. I think we need little community offices staffed by nurses so that we have a staged care, that they can be screening and provide what's service they can. The primary care physician can provide the care that he and she has skills at. And then there's an occasional person who needs to go to a neurologist or a geriatric psychiatrist or a geriatrician because they've got a special problem. And figuring that out and how to reimburse for it and setting up these systems seems to me to make most sense. And we need to test the models, I think, as Dan said.
I think, Dr. Richie, you had a comment?
Yes, thank you. Just on the general issue of access and improving access to mental health care services, there's a very innovative program right now being conducted by the Department of Psychiatry at University of Washington in conjunction with something called the Puget Sound Healthcare System, where they actually park a shrink in a primary care office, and it was initially, skeptically received by the primary care doctors involved. But after a few months of having such readily available access to mental health care services, the primary care doctors just embraced it entirely. And the compensation package, if you will, or funding was in the source of a contract for services rather than a fee-for-service type of schedule. Very innovative. The chairman of the department at University of Washington came and gave a grand rounds at Vanderbilt within the last 6 months or so and presented this. It was very well received. That might be one cogent answer to your question.
We have the final question here. Right there, at her TikTok, right there. I just want to make a comment while we're preparing that. I think that the Affordable Care Act and the movement toward population-based health is something that we have not taken advantage of. If you have the financial structure such that you need everybody working to take care of a population, and that population is a population of older adults, now you have the reimbursement systems in place. That means you can bring to bear all the healthcare services that are available to handle that population. And that's what the Affordable Care Act has sort of at least generated. So for those of you who are working at affordable care, accountable care organizations, or at hospitals that are thinking about becoming a part of accountable care organizations or practices that will be doing so in the near future, you need to help drive that home to the powers that be so they understand the financial implications of having all of these systems in place to enhance their reimbursement structures. Final question was at this table, this lady here.
Is that you? I will say that I'm at the VA, and decentralized psychiatry is at the VA now, and actually so are the caregiver programs, where family is reimbursed for care. But no, my other question was actually answered.
Okay. Well, in that case, we're going to bring up Grace Smith, who's going to tell you about our next set of festivities.
Thank you again to our panel. Let's recognize them. Thank you all.